The management of severe pre-eclampsia and eclampsia. Purpose and scope. Severe pre-eclampsia and eclampsia are relatively rare but serious complications of pregnancy, with around 5 over 1,000 maternities in the UK suffering severe pre-eclampsia and 5 over 10,000 maternities suffering eclampsia. In eclampsia, the case fatality rate has been reported as 1.8%, and a further 35% of women experience a major complication. The confidential inquiries into maternal deaths persistently show substandard care in a significant percentage of the deaths. Introduction and background. Eclampsia is defined as the occurrence of one or more convulsions superimposed on pre-eclampsia. Pre-eclampsia is pregnancy-induced hypertension in association with proteinuria, equivalent to greater than 0.3 grams in 24 hours, with or without edema, and virtually any organ system may be affected. Severe pre-eclampsia is variously defined. There is consensus that severe hypertension is confirmed with a diastolic blood pressure of greater than or equal to 110 mm of mercury on 2 occasions, or systolic blood pressure of greater than or equal to 170 mm of mercury on 2 occasions, and that, together with significant proteinuria, at least 1 gram per liter. These constitute severe pre-eclampsia. There is less agreement about the degree of moderate hypertension, which, together with other symptoms or signs, constitutes severe pre-eclampsia. A diastolic blood pressure of greater than or equal to 100 mm of mercury on 2 occasions and significant proteinuria with at least 2 signs or symptoms of imminent eclampsia will include many women with severe pre-eclampsia, although it is to be remembered that some women who present with eclampsia have no prodromal signs. An important variant of severe pre-eclampsia is the HE-LLP syndrome that stands for hemolysis, elevated liver enzymes, and low platelet count. Ultimately, as many clinical criteria are subjective, women should be managed according to a careful clinical assessment rather than relying on overly precise criteria. Clinical features of severe pre-eclampsia, in addition to hypertension and proteinuria, are the following: symptoms of severe headache, visual disturbance, epigastric pain and/or vomiting, signs of clonus, papilloedema, liver tenderness, platelet count falling to below 100 multiplied by 10 to the 6th power per liters, abnormal liver enzymes, ALT or AST, rising to above 70 microunits per liter, and the HELLP syndrome. Assessment and diagnosis. Assessment of the woman. How should women be assessed at initial presentation? Although the classification of severity is primarily based on the level of blood pressure and the presence of proteinuria, clinicians should be aware of the potential involvement of other organs when assessing maternal risk, including a placental disease with fetal manifestations. Senior obstetric and anesthetic staff and experienced midwives should be involved in the assessment and management of women with severe pre-eclampsia and eclampsia. Some women will present with convulsions, abdominal pain, or general malaise. In these cases, pre-eclampsia should always be considered and the blood pressure taken and the urine analyzed. Clinical symptoms are important components of worsening disease, particularly headache and abdominal pain. However, increasing edema is not in itself a sign that should determine management. Maternal tendon reflexes, although useful to assess magnesium toxicity, are not of value in assessing the risk of convulsion, although the presence of clonus may be. Continuous oxygen saturation monitoring with a pulse oximeter is valuable, as will often give early signs of pulmonary edema. How should the blood pressure be taken? When taking blood pressure, the woman should be rested and sitting at a 45-degree angle. The blood pressure cuff should be of the appropriate size and should be placed at the level of the heart. Multiple readings should be used to confirm the diagnosis. Korotkov phase 5 is the appropriate measurement of diastolic blood pressure. The method used should be consistent and documented. Automated methods need to be used with caution as they may give inaccurate blood pressure readings in pre-eclampsia. It is important to standardize methods of blood pressure assessment with the women appropriately precisioned. Multiple readings are required to accurately assess blood pressure because of natural variation. Automated methods can systematically underestimate, particularly the systolic blood pressure. It has been suggested that mercury sphygmomanometers should be used to establish baseline blood pressure as a reference unless the automated machine has been validated in pregnancy. However, many units no longer have mercury sphygmomanometers, and so a baseline check with another validated device would be an alternative. How should proteinuria be measured? The usual screening test is visual dipstick assessment. A 2+ dipstick measurement can be taken as evidence of proteinuria, but ideally a more accurate test, either a spot protein creatinine ratio or ideally a 24-hour urine collection, is required to confirm this. There is poor predictive value from urine dipstick testing. Approximate equivalence is 1 plus equals to 0.3 grams per liter, 2 plus equals to 1 grams per liter, and 3 plus is equal to 3 grams per liter. False negative as well as false positive rates are recorded with the use of visual dipstick assessment. Problems can be reduced by training. An automatic dipstick reader can overcome some of the observer error found with urinary dipsticks. Newer techniques such as protein or creatinine ratios have not been fully evaluated but may be a valid alternative. A level of 0.03 grams per millimoles appears to be equivalent to 0.3 grams per 24 hours. In view of the high false positive rates with dipsticks, laboratory testing, usually by 24-hour urine collection, is recommended to confirm significant proteinuria unless the clinical urgency dictates immediate delivery. How should the woman be monitored? The blood pressure should be checked each 15 minutes until the woman is stabilized, and then every 30 minutes in the initial phase of assessment. The blood pressure should be checked 4-hourly if a conservative management plan is in place and the woman is stable and symptomatic. Assessment of the woman requires a full blood count, liver function, and renal function tests. This should be repeated at least daily when the results are normal, but more often if the clinical condition changes or if there are abnormalities. Clotting studies are not required if the platelet count is over 100 multiplied by 10 to the 6th power per liters. Close fluid balance with charting of input and output is essential. A catheter with an hourly urimeter is advisable in the acute situation, especially in the immediate postpartum period. In pre-eclampsia, there can be a rise in uric acid that correlates with poorer outcome for both mother and baby. The rise confirms a diagnosis of pre-eclampsia and confers an increased risk to the mother and baby, but the levels in themselves should not be used for clinical decision making. Renal function is generally maintained in pre-eclampsia until the late stage unless HELP syndrome develops. If creatinine is found to be elevated early in the disease process, underlying renal disease should be suspected. In severe disease, serum creatinine can be seen to rise and is associated with a worsening outcome, but renal failure is now uncommon in pre-eclampsia in the developed world, and when it does occur, it is usually associated with hemorrhage, HELLP syndrome, or sepsis. A falling platelet count is associated with worsening disease and is itself a risk to the mother. However, it is not until the count is less than 100 multiplied by 10 to the 6th power per liter there may be an associated coagulation abnormality. A platelet count of less than 100 should be a consideration for delivery. A diagnosis of HELLP syndrome needs confirmation of hemolysis either by LDH levels or by blood film to look for fragmented red cells. An AST or ALT level of above 70 international units per liter is seen as significant, and a level above 150 international units per liter is associated with increased morbidity to the mother. The platelet count would have to be below 100 multiplied by 10 to the 6th power to support the diagnosis. How should the fetus be assessed? In the acute setting, an initial assessment with cardiotocography should be undertaken. This gives information about fetal well-being at that time but does not give any predictive information. Women in labor with severe pre-eclampsia should have continuous electronic fetal monitoring. If conservative management is planned, then further assessment of the fetus with ultrasound measurements of fetal size, umbilical artery Doppler, and liquor volume should be undertaken. Serial assessment will allow timing of delivery to be optimized. The value of Doppler in other fetal vessels has yet to be clarified. The main pathology affecting the fetus, apart from prematurity, is placental insufficiency leading to intrauterine growth restriction or IUGR. Intrauterine growth restriction occurs in around 30% of pre-eclamptic pregnancies. Ultrasound assessment of fetal size at the time of the initial presentation with hypertension is a valuable one-off measurement to assess fetal growth. Growth restriction is usually asymmetrical, so measurement of the abdominal circumference is the best method of assessment. Reduced liquor volume is also associated with placental insufficiency and fetal growth restriction. Serial estimations of liquor volume can detect fetal compromise. Randomized trials have shown that investigation with umbilical artery Doppler assessment using absent or reverse end diastolic flow improves neonatal outcome, and serial investigations of this and other fetal vessels can be used to follow pregnancies under treatment and optimize delivery. Management of severe pre-eclampsia. The management of severe pre-eclampsia is based on careful assessment, stabilization, continued monitoring, and delivery at the optimal time for the mother and her baby. This means controlling blood pressure and, if necessary, convulsions. Senior obstetric and anesthetic staff and experienced midwives should be involved. How should we control the blood pressure? Antihypertensive treatment should be started in women with a systolic blood pressure over 160 millimeters of mercury or a diastolic blood pressure over 110 millimeters of mercury. In women with other markers of potentially severe disease, treatment can be considered at lower degrees of hypertension. Labetalol given orally or intravenously, nifedipine given orally, or intravenous hydralazine can be used for the acute management of severe hypertension. In moderate hypertension, treatment may assist a prolongation of the pregnancy. Clinicians should use agents with which they are familiar. Atenolol, angiotensin-converting enzymes, or ACE inhibitors, angiotensin receptor blocking drugs, or ARB, and diuretics should be avoided. Nifedipine should be given orally, not sublingually. Labetalol should be avoided in women with known asthma. There has been a general consensus that blood pressure greater than 170/110 millimeters of mercury requires treatment in the maternal interest, although this is not supported by randomized trials. There is, however, a clear rationale supported by the desire to prevent the known risk of vascular damage due to uncontrolled hypertension. The confidential inquiries into maternal deaths have suggested a lower threshold of 160 millimeters of mercury systolic. The preferred therapeutic agents are labetalol, nifedipine, or hydralazine. Labetalol has the advantage that it can be given initially by mouth in severe hypertension and then, if needed, intravenously. There is also a consensus that if the blood pressure is below 160/100 millimeters of mercury, there is no immediate need for antihypertensive therapy. An exception may be if there are markers of potentially more severe disease, such as heavy proteinuria, or disordered liver, or hematological test results. Since in this situation, alarming rises in blood pressure may be anticipated, antihypertensive treatment at lower blood pressure levels may be justified. There is continuing debate concerning women with a blood pressure between 100 millimeters of mercury and 110 millimeters of mercury diastolic. Maternal treatment is associated with a reduction of severe hypertensive crisis and a reduction in the need for further antihypertensive therapy. However, there appears to be a small reduction in infant birth weight. With treatment, a prolongation of pregnancy of an average of 15 days is possible as long as there is no other reason to deliver. Methyldopa and labetalol were the most commonly used therapies in the UK. Doctors use the drug with which they are familiar. Atenolol is associated with an increase in fetal growth restriction. ACE inhibitors and ARBs would appear to be contraindicated because of unacceptable fetal adverse effects. Diuretics are relatively contraindicated for hypertension and should be reserved for pulmonary edema. How should seizures be prevented? Magnesium sulfate should be considered for women with pre-eclampsia for whom there is concern about the risk of eclampsia. This is usually in the context of severe pre-eclampsia once a delivery decision has been made and in the immediate postpartum period. In women with less severe disease, the decision is less clear and will depend on individual case assessment. The MAGPIE study, or the magnesium sulfate for prevention of eclampsia, has demonstrated that administration of magnesium sulfate to women with pre-eclampsia reduces the risk of an eclamptic seizure. Women allocated magnesium sulfate had a 58% lower risk of an eclamptic seizure. The relative risk reduction was similar regardless of the severity of pre-eclampsia. When conservative management of a woman with severe hypertension and a premature fetus is made, it would be reasonable not to treat until the decision to deliver has been made. If magnesium sulfate is given, it should be continued for 24 hours following delivery or 24 hours after the last seizure, whichever is the latter, unless there is a clinical reason to continue. When magnesium sulfate is given, regular assessment of the urine output, maternal reflexes, respiratory rate, and oxygen saturation is important. How should seizures be controlled? The principles of management should follow the basic principles of airway, breathing, and circulation. Magnesium sulfate is a therapy of choice to control seizures. A loading dose of 4 grams should be given by infusion pump over 5 to 10 minutes, followed by a further infusion of 1 gram per hour, maintained for 24 hours after the last seizure. Recurrent seizures should be treated with either a further bolus of 2 grams of magnesium sulfate or an increase in the infusion rate to 1.5 grams or 2.0 grams per hour. Do not leave the woman alone but call for help, including appropriate personnel such as the anesthetist and senior obstetrician. Ensure that it is safe to approach the woman and aim to prevent maternal injury during the convulsion. Place the woman in the left lateral position and administer oxygen. Assess the airway and breathing and check pulse and blood pressure. Pulse oximetry is helpful. Once stabilized, plans should be made to deliver the woman, but there is no particular hurry and a delay of several hours to make sure the correct care is in hand is acceptable, assuming that there is no acute fetal concern such as a fetal bradycardia. The woman's condition will always take priority over the fetal condition. Magnesium sulfate is a therapy of choice, and diazepam and phenytoin should no longer be used as first-line drugs. The intravenous route is associated with fewer adverse effects. Magnesium toxicity is unlikely with these regimens, and levels do not need to be routinely measured. Magnesium sulfate is mostly excreted in the urine. Urine output should be closely observed, and if it becomes reduced below 20 milliliters per hour, the magnesium infusion should be halted. Magnesium toxicity can be assessed by clinical assessment as it causes a loss of deep tendon reflexes and respiratory depression. If there is a loss of deep tendon reflexes, the magnesium sulfate infusion should be halted. Calcium gluconate of 1 gram or 10 milliliters over 10 minutes can be given if there is concern over respiratory depression. If there are repeated seizures, then alternative agents such as diazepam or thiopenton may be used, but only as single doses, since prolonged use of diazepam is associated with an increase in maternal death. If convulsions persist, intubation is likely to be necessary to protect the airway and maintain oxygenation. Transfer to intensive care facilities with intermittent positive pressure ventilation is appropriate in these circumstances. How should fluid balance be managed? Fluid restriction is advisable to reduce the risk of fluid overload in the intrapartum and postpartum periods. In usual circumstances, total fluids should be limited to 80 milliliters per hour or 1 milliliters per kilogram per hour. Over the last 20 years, pulmonary edema has been a significant cause of maternal death. This has often been associated with inappropriate fluid management. There is no evidence of the benefit of fluid expansion, and a fluid restriction regimen is associated with good maternal outcome. The regime of fluid restriction should be maintained until there is a postpartum diuresis, as oliguria is common with severe pre-eclampsia. If there is associated maternal hemorrhage, fluid balance is more difficult and fluid restriction is inappropriate. Planning delivery. When and how should the baby be delivered? The decision to deliver should be made once the woman is stable and with appropriate senior personnel present. If the fetus is less than 34 weeks of gestation and delivery can be deferred, corticosteroids should be given, although after 24 hours, the benefits of conservative management should be reassessed. Conservative management at very early gestations may improve the perinatal outcome, but must be carefully balanced with maternal well-being. The mode of delivery should be determined after considering the presentation of the fetus and the fetal condition, together with the likelihood of success of induction of labor after assessment of the cervix. The third stage should be managed with 5 units intramuscular syntocinon or 5 units intravenous syntocinon given slowly. Ergometrin or syntometrin should not be given for prevention of hemorrhage, as this can further increase the blood pressure. The delivery should be well planned, done on the best day, performed in the best place, by the best route, and with the best support team. A few hours delay in delivery may be helpful if it allows the neonatal unit to be more organized or to transfer a mother to a place where a cot is available. This assumes the mother is stable before delivery and prior to transfer. If the gestation is greater than 34 weeks, delivery after stabilization is recommended. If less than 34 weeks, and the pregnancy can be prolonged in excess of 24 hours, steroids help to reduce fetal respiratory mortality. There is a probable benefit from steroid therapy even if delivery is less than 24 hours after administration. In all situations, a carefully planned delivery suiting all professionals is appropriate. Vaginal delivery is generally preferable, but if gestation is below 32 weeks, cesarean section is more likely as the success of induction is reduced. After 34 weeks with a cephalic presentation, vaginal delivery should be considered. The consultant obstetrician should discuss the mode of delivery with the mother. Vaginal prostaglandins will increase the chance of success. Antihypertensive treatment should be continued throughout assessment and labor. How should the woman be managed following delivery? Clinicians should be aware of the risk of late seizures and ensure that women have a careful review before discharge from hospital. Antihypertensive medication should be continued after delivery as dictated by the blood pressure. It may be necessary to maintain treatment for up to 3 months, although most women can have treatment stopped before this. Women with persisting hypertension and proteinuria at 6 weeks may have renal disease and should be considered for further investigation. Clinicians should be aware that up to 44% of eclampsia occurs postpartum, especially at term, so women with signs or symptoms compatible with pre-eclampsia should be carefully assessed. Severe pre-eclampsia or eclampsia can occur in the postpartum period. Up to 44% of eclampsia has been reported to occur postnatally, especially in women presenting at term. Women who develop hypertension or symptoms of pre-eclampsia postnatally, such as headaches, visual disturbances, nausea and vomiting, or epigastric pain, should be referred for a specialist opinion and investigation to exclude pre-eclampsia. Women who deliver with severe pre-eclampsia or eclampsia should have continued close observation postnatally. As eclampsia has been reported after 4 weeks postnatally, the optimum length of inpatient postnatal stay is unclear, but the incidence of eclampsia and severe pre-eclampsia falls after the 4th postpartum day. The decision about discharge from hospital needs to take account of the risk of late seizures. Most women with severe pre-eclampsia or eclampsia will need inpatient care for 4 days or more following delivery. Careful review to ensure improving clinical signs is needed before discharge. Antihypertensive therapy should be continued after delivery. Although initially, blood pressure may fall, it usually rises again at around 24 hours postpartum. A reduction in antihypertensive therapy should be made in a stepwise fashion. There is no reason why the women cannot go home on treatment to be weaned off therapy as an outpatient. After pre-eclampsia, blood pressure can take up to 3 months to return to normal. During this time, blood pressure should not be allowed to exceed 160 over 110 millimeters of mercury. Currently, there is insufficient evidence to recommend any particular antihypertensive. However, it is good practice to avoid the use of alpha methyldopa in the postnatal period because of its adverse effect profile, particularly depression. In breastfeeding women, labetalol, atenolol, nifedipine, and enalapril are currently in use either singly or in combination. Corticosteroids have been used in HELLP syndrome. The current evidence suggests they lead to a more rapid resolution of the biochemical and hematological abnormalities, but there is no evidence that they reduce morbidity. Follow-up and final diagnosis. What should be offered following hospital discharge? An assessment of blood pressure and proteinuria by the general practitioner at the 6 weeks postnatal check is recommended. If hypertension or proteinuria persist, then further investigation is recommended. Women whose pregnancies have been complicated by severe pre-eclampsia or eclampsia should be offered a formal postnatal review to discuss the events of the pregnancy. Preconceptual counseling should be offered where the events that occurred, any risk factors, and any preventative therapies can be discussed. Evidence suggests that up to 13% of women with pre-eclampsia will have underlying chronic or essential hypertension that was not suspected antenatally.